Hello. Looks like most people are coming back. Okay, I think I see everyone now. Um, there was a question about the math too, the calculation quiz that you have for this week. And I went in and tried to see why it wasn't open. And on my end, it's showing publish. So it should be open to you, but I don't think it is. You're not able to click on it, right?
Which one? The one that we were supposed to do by ourselves? Like the
Yeah.
quiz?
Yes.
Did it yesterday.
Oh, okay. So it opened up yesterday evening for you then?
It did.
Okay. It just didn't look like it was opening. Um, and it should. Someone asked when you were supposed to do it. So if it's accessible to you this week, you do it anytime you want this week. The deadlines are there, so it would be Sunday night of this coming Sunday night. I don't know what the date is, but before Sunday night. Um, if you have trouble opening it, let me know. Like I said, it says published, so it should be okay. It just didn't look like it was, when I tried to click on it, didn't look like it was opening for me, but that was on my end. So I thought maybe you all were having trouble opening it too. But if Aurelia was able to do it, then everyone else should be able to get into it. Okay. Do you have any questions before we get started tonight? All right, I'm going to pull up our PowerPoint. Can you all see the PowerPoint? No, not showing. Okay. How about now? We good? Okay. Okay. This afternoon, we're going to talk about high risk complications of pregnancy and really just a few specific ones. We're going to start with pregnancy associated nausea and vomiting and hyperemesis gravidarum. Um, there's a difference between the two, and there's always someone in the class that has had hyperemesis gravidarum and can tell us that it's not the same thing. There's always someone who's had that experience and is willing to share it with us. So pregnancy associated nausea and vomiting is something that starts around, maybe 4 to 6 weeks of pregnancy, right after the hormone changes start to happen. And we often say it's actually a good sign that you're feeling that nausea, because as pregnancy hormones start to change, the hormone levels increasing is what causes the nausea to happen. So if hormone levels don't change, it's hard for our bodies to sustain that pregnancy. So that nausea that's a symptom of the hormone changes is actually a good thing um, in early pregnancy. It usually resolves in about 12 to 16 weeks, right towards the end of that first trimester. So as hormone levels start to kind of even out, the nausea and vomiting will subside. It's a mild to moderate problem when we talk about the severity of it. It's something that we can usually tolerate. We usually tell women to try things like 7-Up and um, crackers, pretzels, salty foods, things like that that will help with the nausea. But we tried that before we tried medications. Um, and then pharmacological interventions are always a possibility, something that we'll use, but not a first line go-to with it. Something that we see a lot of women trying is ginger, and ginger ale is perfectly safe. Any of those types of drinks are fine. Um, where you want to be careful is if you have moms who are trying to make their own ginger tea, because they can get the concentration of fresh ginger a little high, and ginger is known to cause preterm labor. So if they're buying a pre-made ginger tea that they're steeping, that's probably going to be just fine. But if they're making it themselves from scratch, the concentration of ginger could be excessive, and um, it could trigger preterm labor. So if they're someone who's doing all natural kinds of things, they need to be cautioned to be careful with that. Again, nausea and vomiting with pregnancy is not uncommon, and dehydration usually does not become an issue. It's usually self-limiting. We talk to moms about just keep drinking. That's usually enough to prevent dehydration. And the electrolyte imbalances does not occur usually with just the pregnancy related nausea and vomiting. So it's uncomfortable. It makes life a little bit miserable for those first few weeks of pregnancy, but it's not harmful to the baby, and it's really not harmful to mom. Now, if it's what we diagnose as hyperemesis gravidarum, it is excessive. Okay, it's persistent, and there are complications that can occur with hyperemesis gravidarum that's not seen in nausea and vomiting with pregnancy. It usually starts around the same time. The textbook's going to tell you probably 4 to 10 weeks. So it's going to start around the same time. You're not going to be able to tell a difference in the onset. But it can last through the second and third trimester. So it doesn't end when the hormone levels level out at the end of the first trimester. So these women may be sick the entire pregnancy. And then you're looking at when we kind of rank it in nausea and vomiting being mild to moderate. This is moderate to severe, and it's debilitating. These women, they can't go out of the house, they can't go to work, students can't go to school. I mean, it's uncontrollable vomiting all day long. You know, a lot of times the pregnancy related nausea and vomiting is more in the morning. Once people are up moving around and have eaten a little bit, it kind of subsides, but not hyperemesis gravidarum. It's all day long. And sometimes even with intervention, it's uncontrollable. We can't get it to stop. With hyperemesis gravidarum, usually there's not, with nausea and vomiting in pregnancy, usually there's not a weight loss with it. They're able to keep enough down that they can maintain their weight. But with the hyperemesis gravidarum, you typically, with that diagnosis, have a weight loss of greater than 5% of their pre-pregnancy weight. So a significant weight loss associated with it as well. What else do we need to talk about with that? Electrolyte imbalances, where you don't see it with the nausea and vomiting because they're able to keep enough down and they're keeping enough fluids in that you're not having the electrolyte involvement. With hyperemesis gravidarum, you do have electrolyte imbalances. Most commonly is decreased potassium, and then you have metabolic alkalosis with it from all of the vomiting. So it's managed medically and pharmacologically. Questions about those two or the difference between them? When I say medically and pharmacologically, we're giving medications for antiemetics for the nausea and vomiting, but we're often doing IVs. They're hospitalized. We're doing IVs and replacing some electrolytes. And there are even situations where moms will end up with a feeding tube if it lasts throughout the pregnancy. So it can be severe and, like I said, debilitating. Okay. Another condition that we see that is a complication of pregnancy is hypertension. And then we have preeclampsia, when hypertension gets out of control or has other symptoms associated with it. We can have just hypertension alone, and we'll talk a little bit about the differences. You can have chronic hypertension that is before your 20 weeks gestation, so it's not considered gestational hypertension. It's chronic. If it's after 20 weeks of gestation, we consider it gestational hypertension. To be diagnosed with hypertension, it has to be 140 over 90 on two separate readings. And at least those have to be at least 4 hours apart. So just because a patient comes into the office and you take a blood pressure and their pressure is 148 over 100, and then before they leave the office that day, you take it and it's 142 over 98, that doesn't give them a diagnosis of hypertension because that's not within that 4 hour or outside that 4 hour time frame. So we're going to have to bring them back. If you have a morning appointment, bring them back later in the day, or bring them back the next day and get another reading to make sure that their blood pressure wasn't just elevated that as an incidental finding, and then it is staying up. So we're looking, again, that's important that it's two separate measurements that is elevated to that criteria at least 4 hours apart or more. Then when we're looking at preeclampsia, we're looking at a reading of 160 over 110 as our readings. And we're looking at that to be paired with one other symptom. Okay, so another symptom to make the diagnosis of preeclampsia. Okay, let's talk about some of hypertension and preeclampsia before we move on to a case study scenario. With preeclampsia, you're going to see some other symptoms that follow along with it. It's that you, in order to make that diagnosis, one of the things that we see is proteinuria, because the kidneys are not being perfused well. So there's protein spilling over in the urine. You may see decreased platelets, and the terminology for that is thrombocytopenia. So you may see proteinuria, thrombocytopenia. You may see increased liver enzymes. And one of the things that are associated with increased liver enzymes is tenderness in the right side, because the liver may be enlarged and they'll have some tenderness there. You can feel that. If they're complaining of epigastric pain or right-sided tenderness, you're going to palpate and see if you can feel an enlarged liver. But if you do, you're going to probably also have elevated liver enzymes with it. These clients with preeclampsia often have a severe headache that's not relieved with Tylenol. They also have visual, we call them visual disturbances. It can be a varied complaints. They may complain of spots before their eyes. They may complain of like squiggly lines. They may complain of just blurred vision, but we kind of clump it into a category and just say visual disturbances. There's something going on with them visually, as well as the severe headaches. Sometimes they have shortness of breath because of fluid buildup in their lungs. Occasionally have nausea and vomiting. It's not something that I see often, but it happens often enough that it's on your list of associated symptoms with preeclampsia. One of the things that we look at very closely is weight gain, because sometimes we'll see that weight gain even before we see the increase in the blood pressure. And we call it weight gain or edema, and especially noticeable in the hands and the face. And that's not typically where you gain weight when you're pregnant. Okay, you might get a little puffy and swollen in your ankles and other places during pregnancy, but your hands and your face are not the places that typically swell. So as we get to know our clients and what they look like when they come in, if they have swelling in their face, their nose kind of looks wide, or they have what we call periorbital edema, so swelling around their eyes and across the bridge of their nose, that's a significant finding that we're going to want to start watching their blood pressure, because if you have that periorbital edema paired with the increase in the blood pressure, that gives you a diagnosis of preeclampsia. And then you're going to start looking for things like proteinuria and the elevated liver enzymes. You're going to be looking for other symptoms as well. Questions so far? Okay. We really don't know what causes preeclampsia. If we did, we might be able to stop it before it starts. But we really don't know for sure what causes it. There are some theories. We know that it probably is stimulated by something going on in the placenta, because the blood vessels are very are affected. So if they're doing pathology on a placenta of a patient who has had preeclampsia, they notice changes in the blood vessels in the placenta. So we feel like that there's probably some correlation there in blood vessel development that maybe triggers the preeclampsia, and that's been in the latest Mayo research that I've seen. Some other things that may or may not, we just don't know, trigger it would be gestational hypertension or chronic hypertension. And we know that those are risk factors that increase your likelihood of having preeclampsia, but do they necessarily trigger that? We don't know. We often will have a diagnosis of something like, it'll be stated something like chronic hypertension with superimposed preeclampsia. So that would be your patient come in and let me see if we've got someone popped in here. Someone came in for their first prenatal visit at 8 weeks of pregnancy, and they were already hypertensive. So that's a diagnosis of chronic hypertension, right? Because it's before 20 weeks. So they have chronic hypertension, and then later on, they're going to be diagnosed with preeclampsia. So the diagnosis would be chronic hypertension with superimposed preeclampsia. Okay, so things that make you at high risk of developing it. We've talked about the hypertension perspective. A previous pregnancy with preeclampsia makes you at greater risk. Multiple gestation pregnancies. So if you have twins or triplets, you're going to be at greater risk of developing preeclampsia. If you have kidney disease, we find that those moms are at greater risk. Any kind of autoimmune disorder, you may be at greater risk. And if you have had in vitro fertilization as your method of becoming pregnant, that puts you at greater risk as well. Some other things that put you at moderate risk are if it's your first pregnancy with this current partner. So we know that there is some aspect of dad having something to do with why you might be preeclamptic. And we don't really know how that plays into it, but it does make a difference. Obesity and family history also make a difference. Women of greater age, so if you're 35 years old or older, you're more at risk. And if you've had complications with your first pregnancy, it doesn't matter what kind of complications, a complicated pregnancy puts you at greater risk. Or if it's been 10 years since your last pregnancy, you are at greater risk. There are some socioeconomic factors that have been identified, but we don't know if those are really factors that maybe lower income clients are at greater risk. We know that they are, but we don't know why. Is it because of nutrition? Maybe they don't have as many healthy foods, or is it more leaning toward that maybe they didn't have prenatal care? They weren't on folic acid, they didn't have prenatal vitamins, so or they didn't have gas money to get to their prenatal visits, and the symptoms of preeclampsia were identified later, and therefore outcomes weren't as good. So we know there's socioeconomic factors that influence the outcome of preeclampsia. We just don't know exactly the extent of them. It's not been studied enough to know exactly what the ramifications of that are. Some of the complications that we see with newborns who have been delivered from moms that have had preeclampsia are fetal growth restriction. So we have tiny babies because they're not getting a good blood supply and good nutrients, good oxygenation when mom's blood pressure is up and perfusion to the placenta is not good. We have preterm birth. So one of the ways that we cure, or actually the only way that we cure preeclampsia, is to get that baby delivered. They truly try to get them to 34 weeks if there's any way possible. If it's someone who is going from preeclampsia into eclampsia or has gone past that marker. And do you know what the marker is that makes you eclamptic? Somebody unmute themselves and tell me. When are you eclamptic and not preeclamptic? Once you have a seizure, you are no longer preeclamptic, you are eclamptic, and they have to get that baby out. Okay. If we have signs that you are headed in that direction, they're going to go ahead and get you delivered as soon as possible. But they really like to get a patient to 34 weeks. So they're going to watch liver enzymes. They're going to watch protein in the urine, probably start magnesium. And magnesium sulfate is the drug that we use to prevent seizure activity. It will lower your blood pressure somewhat, but the primary reason that we use it is to lower seizure activity. So if you ever have a question that says, what's the priority reason, or um, what is, how do you know that the magnesium sulfate has been effective for its priority function, and that's preventing seizure activity. Okay. Placental abruption is a complication as well, and it's directly related to the high blood pressure. HELP syndrome is associated with preeclampsia. And HELP syndrome is just an acronym for hemolysis, elevated liver enzymes, and low platelets. Okay, and when you, if you have questions about it, you can break it down, and it tells you exactly what you're going to see in your lab values. So hemolysis is hemolysis of red blood cells. Okay, elevated liver enzymes. So your liver enzymes are going to go up, and your platelets are going to go down. Okay, so HELP is hemolysis, elevated liver enzymes, and low platelets. And the hemolysis is of it's destruction of red blood cells. So your destruction of red blood cells happens, you have your elevated liver enzymes and your low platelets. It can develop very quickly, and you can even develop HELP syndrome without preeclampsia as a precursor. So it can develop without any symptoms before. Okay, it can develop very quickly. And once you have HELP syndrome, it can be life-threatening. So it's something that has to be addressed very quickly and aggressively. It's when we talked, it was probably the first class when we were talking about failure to recognize and failure to respond appropriately. This is one of the times, a nurse's actions are very important, because if we fail to recognize elevated liver enzymes and low platelets and the destruction of those red blood cells, when we see lab values come back, we often see them as a nurse before the physician sees them. So if you get lab values back that are consistent with this, you need to be calling the physician and say, hey, this is what I saw. What are we going to do about this? Because the physician may not make rounds until tomorrow. If this is someone you see in triage or routine lab work, they may not see it right away. So it's going to be your job as the nurse to identify this and bring it to their attention. You're the advocate for that patient. So it's really important that you recognize it and advocate for your patient, because failure to recognize puts that patient at risk. Cheryl, I need you to turn your camera on for me, please.
Oh,
it shut off
sorry.
again, didn't it? That's okay.
All right, I'll
Also,
figure it out.
we talked about eclampsia being the line that's drawn in the sand, is when you have a seizure. There's also circumstances where there isn't exactly seizure activity, but a patient will go into a coma. And that, again, is the point when they've gone from preeclampsia into eclampsia. But it can happen even without symptoms. So these patients who are showing odd at lab levels, or you have an odd feeling about them, you need to watch them really carefully, because there are risk factors that things can happen without those outward symptoms that we're looking for always. So you're going to be looking for the swelling in their hands and feet, the elevated blood pressure, the headache, the right-sided tenderness. you're going to be looking for all of those symptoms or those complaints, but also you want to keep in mind that those things can happen symptom-free. So it's something to always keep in the back of your mind when you're working in obstetrics, that you have to be aware of those things. Questions? Okay, let me get back to our slides here. Okay, you have a 38-year-old female patient who's 36 weeks pregnant and arrives to labor and delivery for a headache that won't go away with acetaminophen. The patient states, "I keep seeing floaters, and I've even thrown up from it. I do have some swelling and my upper abdomen has really been hurting. My head is really hurting." The nurse notes that the patient's blood pressure is 156/98. What are your concerns with this patient?
Is it the
Seizures.
seizures?
Preeclampsia. And could she be at risk of seizures? Absolutely. She's got the headache that doesn't go away with the acetaminophen, right? And she's describing the visual disturbances as seeing floaters. So I was saying earlier, you hear patients describe them all sorts of ways. She's experienced some nausea and thrown up. She has some swelling in her upper abdomen. So we talked about that swelling in the upper right-hand side over the liver. And her blood pressure is 156/98. So that's definitely in that range that we're going to be concerned about. So they probably would start her on some MAG, and at 36 weeks, try to go ahead and get her delivered. Again, that's the only cure, is delivery. Very good. Okay. We talked about this already. Okay. We didn't talk about, and do you know what the antidote is for magnesium sulfate?
Calcium gluconate?
Absolutely. Very good. Very good. A patient who's on magnesium sulfate, it relaxes your muscles. So we're going to be monitoring for reflexes. If you are preeclamptic, you're going to be hyperreflexic. Okay, so that's something that we're going to see is very exaggerated reflexes in patients typically. But once the magnesium is started, you're going to see diminished reflexes. And the diaphragm that helps us to breathe is a muscle, and it's not going to work real efficiently once we get their bolus of mag on, and then we start giving them a maintenance dose every couple hours. We need to check very closely to see that they're breathing appropriately. What happens if you have, well, let's just talk about this patient. I think it might be one that's, nope, this is diabetic patient, sorry. What happens if you walk in a patient's room and you are assessing them? Reflexes are relatively normal, but their respirations are like 6. What would you do? Six isn't normal, is it? No.
Oxygenate?
I'm sorry.
Oxygenate the patient?
That would be appropriate.
What was
But
it again? One more time.
yeah, if they have magnesium running, you would turn it off.
Oh, yeah.
Yeah, turn it off. Yeah, you've got to stop. The magnesium is the first thing. And then, yeah, you may need to give them a little oxygen, get a little more on board because they're not going to be breathing very well. One of the things that we're going to do is monitor their magnesium level in their blood. So we're going to be looking at those labs as they come back, but you absolutely have to look at your patient and assess your patient because I've seen patients with very high therapeutic high levels of magnesium who are not breathing well at all. And then I have seen patients who barely are reaching a therapeutic level. So their magnesium levels are very low. And they're hardly breathing. So it doesn't, their lab level doesn't really indicate what you're seeing with the patient. So you have to always be sure you're in there and you're assessing them. Because looking at a lab on paper or on the computer is in no way reflective of what you're going to see in the patient. So got to be looking at them closely and assessing them. Other things that we're looking at is urine output, because the magnesium slows down the kidney function, and you'll have decreased urine output. So you want to monitor that really closely as well. Okay. Here's another, we really haven't talked about diabetes yet. But I know you've read about it. So let's go ahead and do this case study, and then we'll talk a little more about diabetes. Nadia is a 34-year-old Indian ethnic origin who is now 24 weeks into her second pregnancy. Her last pregnancy began 7 years ago. Nadia's BMI is 32.4 kilograms. She is, I don't know what that is, M2, and her father has type 2 gestational diabetes. She was diagnosed during her first pregnancy, and her first baby was born at term weighing 3.8 kilograms. She has been diagnosed with gestational diabetes during this pregnancy by a 3-hour GTT. Okay. Are you concerned about her?
She would be considered high risk, right?
She would be.
BMI?
She's 34 years old, so that she's right there at that borderline. We said anyone over 35 years old would be considered high risk. So she's pushing that. She's 24 weeks gestation, and it's been not 10 years. So we know anyone over 10 years is more at risk. So it's only been 7 years. Her BMI, what's considered obese?
Over 30.
Over 30.
Over 30. She's just barely over the obesity limit, isn't she? Her dad has a history of diabetes. She was diagnosed with her first pregnancy with gestational diabetes, and 3.8 kilograms is a pretty good sized baby. And she's been diagnosed with gestational diabetes already at 24 weeks with this pregnancy. So I think I would be concerned about her. I would be really watching her to make sure that she progresses normally and that she's keeping her blood sugar under control. Okay. Okay, we're going to talk about glycemic control now and why it's important. I'm going to pull you guys up so I can see everyone. Or see no one. Well, there we go. If you have uncontrolled glycemic index early in your pregnancy, the fetus is at risk of birth defects. You are at risk of miscarriage of that baby and growth anomalies. And when we say growth anomalies, you can either have a baby with macrosomia or intrauterine growth restriction. So you can have a big baby or a little baby. It doesn't, we don't necessarily associate one or the other with early glycemic control being out of control, I guess. If your blood sugars are high early in pregnancy, you're going to have a macrosomia. You're going to have a large baby. But if your blood sugars are low, you would have more likelihood of having a small baby with intrauterine growth restriction. So you can have either anomaly with early glycemic index control being out. Our biggest concerns are birth defects and miscarriage with that in early pregnancy. With mom, as far as the glycemic index being out of control early in pregnancy, you're going to see diabetic complications like retinopathy and neuropathy being a problem. You're going to see an increased risk of preeclampsia and increased risk for things like infections, specifically UTIs or candida types infections, because we know that the more sugar in your blood, the more risk you are for infection. So late in pregnancy, there's also risks, but those are typically for the baby macrosomia. So if mom's blood sugar is out of control late in pregnancy, you typically have a large baby. And with a large baby, there's going to be birth complications. So the most significant birth complication that we see is shoulder dystocia. And then you're looking for things like a fractured clavicle, any kind of birth injury that would be related to that large baby. And after delivery, you're going to see hypoglycemia in those babies because they're used to blood sugars running high with mom. And then once maternal blood glucose is no longer on board, then you're going to see babies that can't maintain their blood sugar. So you're going to see hypoglycemia. You're going to see polyhydramniosis. So a lot of fluid around the babies. That's typical of moms who are diabetic. Those babies have a lot of blood sugar in their system, or a lot of sugar in their blood. They're producing a lot of urine, so there's going to be a lot of amniotic fluid around them. We have preterm birth associated with it, as well as stillborn after 36 weeks. So they often induce a diabetic mom around 36, 37 weeks, and we prevent that increased risk of stillborn if we're getting those babies out a little bit early. So when we induce a diabetic mother, we typically think, oh, we're inducing her because the baby's going to be so big. But we know that the risk of stillbirth increases with later gestation. So it's not always just because the baby's big, it's because they're at higher risk of stillborn. With moms in late pregnancy, we see higher risk of preeclampsia. We see increased C-section rates because the baby's big. So the C-section rate increases, and we see worsening in just typical diabetic symptoms, the retinopathy and the neuropathy. So it's really important to monitor and manage diabetic symptoms throughout pregnancy, early symptoms as well as late. So again, kind of as you're studying for your exams, associate what symptoms and what complications you're going to see with early glycemic index out of control versus late. Okay, you guys need a break? Are you okay? Okay. Let's talk about Well, actually, we'll talk about McRoberts' position. That'll give us right at about an hour, and then we'll take a break. McRoberts' position is something that when you have a large baby, for example, with a diabetic mom, or you have a baby who's we call asynclitic, which is coming down through the pelvis at an inappropriate angle and making delivery difficult, and we need as much room as we can possibly get in the pelvis. We will have mom in a lithotomy position, and we will pull her knees back as much as we can. We may have her in stirrups, and then we'll help her pull her knees back, and that's called McRoberts position when it's like a exaggerated lithotomy position that increases the diameter of the pelvis and gives the baby's head more room to come through the pelvis. So important when you have a large baby, not just for the baby's head, but also for the shoulders, especially if you have a large baby with shoulder dystocia. Okay, so look in your book at McRoberts' position, and so you'll be familiar with that on a test, and it will make sense to you when how it gives you extra room. Okay. It is about 3:45, so let's come back at 4:00. How about that? Okay, you can just turn your cameras off, and I will see you back at 4. Have any of you guys been having trouble getting kicked out of Zoom? I saw Valerie's thing. Is she the only one that's getting dropped? I'm sorry, Valerie.
It's okay. I'm in here going crazy. I done logged in like 7 times. I'm like, is it just me?
Oh, I don't know why it's at the same place that you usually log in from?
Hmm.
No?
Yeah, I had turned my computer off and everything because I was like, well, is it my Wi-Fi? But I don't know what's going on.
Hmm. I don't know. Where I used to work, we said every time it rained, our internet server would just drop people, and it acted so weird. We'd always hope that it didn't rain on test day because the students would get so stressed. And I don't know if that had anything to do with it. We blamed it on the rain, but
That's why I was, my blinds are closed. So I was looking like, is it raining outside? And I don't know.
our IT department thought we were crazy, but it's like, really, every time it rains, something goes wacky with our internet. Like, the rain doesn't affect that. I'm like, oh, okay, whatever. But we have to blame something.
Exactly.
Okay. Is it time to be back? I think. Okay. Brianna and Carrie, can you turn your cameras back on for us, please? See your smiling faces? Do you have questions over anything that we've covered? We went through some of those complications pretty quickly. Okay. Kirian and Brianna, can you turn your cameras back on for me, please? Thank you. If I can.
When I sent direct messages, when I
Uh-huh.
got kicked out, did you receive them?
I only saw one. I don't know.
Okay.
Yeah, I don't know why I didn't get more than that.
Okay.
And then I saw where you came back in, you know. Were you waiting in the waiting room very long before I was able to, before I saw
Yes,
it?
ma'am. Yes,
I'm
ma'am.
sorry. Do you have my
Oh,
number? Usually
yes.
if you text me, if you're stuck in the waiting room and I don't see it on here, if you text me, my phone is laying here, so it will light up.
Okay.
So you can, that goes for everybody. If you, something happens and I don't see the chat, you can text me and my phone will light up. So at least that will get my attention.
Okay. Thank you.
You're welcome. Kirian, I need you to come on camera, please. Okay, anytime that you're not on camera and I have to um, move you out because you have to be on camera for your attendance purposes. If I ask you and you don't come back in and I move you and I put you out of Zoom completely, I can't let you back in. That's not an option. So like first time I'll move you to the waiting room, and then once you're in there, I can move you back in if you ask. But once I've moved you out, I can't, like, completely removed you from Zoom. I can't pull you back in. I don't have that ability. So be sure that you try to stay on camera for us. Let's see, what time is it? Go for. Okay. We're going to talk about one of the most scary complications of pregnancy now, and it's bleeding and hemorrhage. Okay, it can be placenta previa or placental abruption. Both of those are bleeding potential, and we have to be able to determine which one we're looking at. So I'm going to go back to the PowerPoint. Can you guys still see the PowerPoint? And it's gone back to, okay. Here's placenta previa and placental abruption. And this is kind of set up like a concept map. I don't know if you all use concept maps in school very much, but they both have bleeding and have severe hemorrhage potential, but there are some factors that are very specific to one or the other. So placenta previa, I'm going to flip on to the next slide, looks like this. And a normal placenta is going to be attached ideally in the fundus of the uterus, so it's going to be up high. If you have a total placenta previa, which is the placenta itself is attached in the lower segment of the uterus and it's crossing the placenta completely, or the cervix completely, there's no way for the baby to be delivered with the placenta still attached. So this baby has to be a C-section, because as this placenta, as the cervix opens, the placenta will bleed out here. If you have a partial placenta previa, sometimes as the cervix starts to open up and the baby grows, you may see this on ultrasound, and that placenta will move up the side of the uterus. So it's possible with a partial placenta previa that the weight of the baby pushing against this little marginal edge, there's possibilities sometimes of delivering over a partial placenta previa. And this would have to be just a small degree, because it would have to be to where as the cervix opened, it really didn't open up the vessels of the placenta here. And what little bit was covering the cervix as the baby's presenting part, which you would hope would be the head, would come down, it would put pressure on it. And you might have just a little trickle of blood that you would see. And sometimes we'll see what we will call a little more bloody show than normal if you have something like this. A marginal placenta previa is the one that you're most likely to be able to deliver through. And again, it would be ideal if the baby's head was down. It was a breech presentation. And as the cervix opened, this little edge of the placenta moves back with the opening of the cervix, and then the baby's head puts pressure against it, and you'll have minimal bleeding. But at any point that the bleeding starts to become excessive, this patient is an emergency C-section, not an urgent one. This is one that you have the surgery table set up and waiting for. Okay, when you have placenta previa, what kind of blood do you think you're going to see? Okay, there's dark red venous blood or bright red bleeding.
Bright
Which one?
red.
Perfect. Yeah, you're going to see bright red bleeding that's coming from the maternal side of the placenta. So bright red bleeding is with placenta previa. Do you think you would see elevated fundal height with placenta previa?
No.
Nope, you're right. That goes with placental abruption. What about severe and steady pain?
No.
Nope, you're right. It's painless bleeding with placenta previa. What about internal cervical Oz partially being covered? Okay, never mind. What
I
about a
had it.
relax? Oh, okay. You want to tell us about your experience?
I mean, I don't even remember how many weeks it was. It was my third child.
Uh-huh.
And I was just laughing one day and there was some blood, you know.
Oh my.
Yeah,
Mhm,
so I was out of town actually. I had to call my OBGYN and he said, "Can you stay lateral as you get back home?"
mhm.
And we did. And there was no pain. He just had to put me on bed rest um, for the rest of the pregnancy and wait for the baby to be born. And now I understand why I had to have a C-section. I didn't know that anatomical part until you just showed it.
Yeah. Um, so how much bleeding did you have? Was it just spotting or was
It was
it?
spotting at first, but
Mhm.
after I got back home and I just started cleaning the kitchen, you know, the things you do. And I
Yeah.
started bleeding again. And he was like, "Do I need to put you in the hospital so you'll stay off your feet?" Yeah.
Yeah.
And I think stress was part of it too that could have done it. So basically, am I right? The placenta is trying to come before the baby. So
Yes, the
the baby
placenta
will
is
die.
down over the cervix.
Hmm.
Yeah. Yeah. So personal experience is one of our best learning tools. I mean, it's the best case study out there. When we talk about simulation and the boards of nursing ask you what kind of simulators you have, and you say, "Oh, I have high fidelity simulation equipment, and it's the top of the line. It's the best on the market." A real person in the bed is the best experience that you can have. So the best learning experiences is we can learn from each other. Um, that's often, until we have an ultrasound showing that a patient has placenta previa, that's often the way they present. They'll come into the triage with some bleeding, and that's how we find it.
Can you go back over which one belongs where?
Sure, yeah.
Bright red bleeding went to placenta previa, right?
Bright red is with placenta previa, yes.
Okay, and then dark red is with placental abruption.
Yes, because it is more the placenta previa is more oxygenated blood coming straight from the maternal side of the placenta. So that's why it's bright red. Okay.
And then what was the third one?
I'm not sure what you mean, the third one.
Didn't we do 3 of them so far?
Oh, I'm going to go back over them. The pain with the two of them with placenta previa, you don't have pain. Did you have pain with your previa at all? Did you even know?
No.
Yeah, usually they don't even know that they're bleeding. It's just like, what's going on? Because there's no reason for the pain. It's just blood vessels are leaking blood out. Now, their placenta previa can, um, well, I don't want to make it confusing. So placenta previa
Oh,
is
yeah.
painless. Go ahead.
I wanted to hear what you had to say, but I was just
Okay.
curious about something.
Mhm.
So on my second childbirth, I had
Mhm.
that vaginally.
Mhm.
Um, and when after the baby come out and I pushed, then my
Mhm.
whole uterus come out and it inverted, like
Yes.
full inversion.
Yes.
So I was just thinking, and that was the worst pain ever when he had to put it back in,
Yes.
and then it later cramps and goes into spots. I think
Yes.
that's why I wanted to be a nurse because I really did not like that nurse overnight. She wouldn't move me when can you imagine that uterus cramping to get back in spot?
Yeah.
Um,
It-
do you think that had anything to do with it or not? I was just thinking.
Um, Probably not. I mean, I don't see a relationship between placenta previa with your first pregnancy
No,
and
that was third. Placenta was third. Pregnancy was third.
placenta previa was third.
Uh-huh. And that's after the second, in which that was my second pregnancy was, what is it, vaginal, in which the
Okay.
uterine completely came out.
Okay. Yeah, it could have something to do with that. Yes, absolutely. Because if you had an inverted uterus with your second pregnancy, yes, by all means, that could have something to do with the placenta not appropriately attaching in the fundus of the uterus where it should with the third pregnancy. I mean, you may even be fortunate that you conceived the third time.
Oh, I was. Yeah.
Yeah.
Yeah, the lungs especially growing. Yeah.
Yeah.
All right. Well, thank you.
Oh, you're welcome. Yeah, anytime that you have the complication of the uterus coming outside after delivery, you can have lots of complications the next pregnancy. Did it happen when they were massaging the uterus, or
Oh, which one? You mean the second one, vaginal?
when the uterus came out? Did it happen when they were massaging?
Yeah, I don't know. I mean, I had to go on Pitocin. I don't go into labor. So that was my first pregnancy was C-section. So the second one was actual delivery.
Mhm.
And I mean, all I know is I think my head spun around 360 degrees and I cussed and I was so embarrassed in front of my sweet doctor. And then my husband was just paying attention to the baby and it just hurt so bad. So I just think it accidentally came out.
Yeah,
Like,
and it does.
yeah.
When we talk about complications, and you'll be reading that in your book too.
I did. Yeah.
That's one of the things that you all will need to know.
Mhm.
When we massage a fundus, and I think we talked about that a couple weeks ago anyway. I always put my hand on just above the pubic bone, because that is a complication that we can cause from massaging the fundus. Now, if you don't massage it, then it's not going to clamp back down. So we have to do it. But one of the things that I like to do myself is just to put my hand there um, and put nice firm pressure as I massage to be sure that I don't push that uterus out, because it can happen. Now it can also invert and come out. Like if someone is trying to guide the placenta out and they pull on it, that's something that you never do. You may put tension on the cord to help guide the placenta out, but you never pull on it, because if you pull on a cord when the placenta hasn't released, you can cause that uterus to invert and come out. Okay. Do you know if your placenta inverted?
Yes, it inverted.
Okay. Yeah. So it was probably from someone pulling on the cord rather than someone massaging your fundus. Does that make sense? If the placenta has not released, like all the blood vessels and all of the tissue that's supporting the baby
Mhm.
should release after it may take a couple minutes, it may take 5-8 minutes after delivery, but all of that should release. And then mom usually says, "Oh, I feel like I need to push again." And what's happening is that placenta has released in there and it's trying to come out. As she's cramping and the uterus is contracting, it's trying to push that placenta out. So if you hold on to the cord and just kind of guide it out, that's okay, but you shouldn't pull on it, because if you pull on it and it hasn't released, you can pull the uterus inside out. So yeah, we don't do that. You just wait on the body to naturally contract and and sometimes we'll even say, "Give me a little push," and when they do, they'll push that placenta out. Okay. Okay, so we'll go back to our slide, talk a little more about it. So we know dark red venous blood with placental abruption, bright red bleeding, very oxygenated blood with placenta previa, straight from the maternal side. No pain with placenta previa, severe steady, constant pain with abruption. It's not like contractions that come and go. It's a steady pain that doesn't ease up. The fundal height may rise with a placental abruption because they may be bleeding out inside and it's not coming out. So if it's what we call a concealed abruption, the fundal height may rise as the blood accumulates inside. And the abdomen may become rigid or firm. What I've noticed is it kind of feels like a basketball in there. You'll have the mushy tissue on top, but then when you hit that uterus, it feels firm. It almost feels like the texture of a basketball. Like you can feel the mushiness down to it, and then it's like, oh, it doesn't. There is no give to it. There's no squishy mushiness, like if you feel the muscle during a contraction, there's still, you have that, you feel a little bit of squish as you get down to the uterus when it's contracting, and then you feel the tightness of the muscle itself. But when you have an abruption and that uterus is tight and rigid from an abrupted uterus, or an abrupted placenta, that uterus feels really firm and hard inside, and it just feels different than a contracting uterus. So as you get used to feeling, it's important that you feel what a normal contracting uterus feels like. So if you have someone who's abrupting, you feel that and you're like, oh, this doesn't feel like a normal contraction. So we need to know what normal feels like. Okay, we looked at that. Okay. Let's talk about some other aspects of both. If you have a previa, you're typically going to see it show up more in the third trimester. So as they're getting towards the end of their pregnancy and the cervix is softening and maybe starting to dilate a little bit, you're going to see spotting or a little bit of bleeding, and that's when you're going to see signs of placenta previa. Now, with our ultrasounds now, where we often know that a patient has placenta previa even before they're symptomatic. But if you talk to a patient who had a baby 30 years ago, when they weren't doing so many ultrasounds, their first sign of placenta previa may have been the bleeding. But now we can see by ultrasound where that placenta is implanted. So we know to warn our patients that, you have we may say it's a total placenta previa or a marginal placenta previa. So this is what you need to be watching for bleeding. So those are things that we talk to our patients about. And another thing that causes abruption, or things that cause abruption, can be accidents. You can have a placental abruption because of an accident, a car accident or a fall can cause an abruption. Let's see if I hear. Nope, Valerie's still here. I was afraid you got kicked off. Something else that causes a abruption are drugs, and specifically cocaine. I have too many times than I care to think about. I've had patients that come in and have symptoms of abrupting, and when I start talking to them, it's like, have you used drugs in the last day or two? And If the answer is yes, has it been cocaine? And the answer is yes. And they are abrupting from using cocaine. Questions about differences between placenta previa and placental abruption? Okay. With either one of them, we really don't control the bleeding. The way we manage it is we prepare for a cesarean section. And that's things like having them sign for surgery, getting an IV inserted, calling the nursery and making sure nursery is ready for this baby that could have bled out due to the bleeding. We're monitoring mom for signs of hypovolemic shock. And when we talk about that, unmute yourselves and tell me what are signs of hypovolemic shock.
Hypotension.
Hypotension.
Increased heart rate.
Yes, that's what I was looking for. Your first one is tachycardia. Your first symptom of shock is tachycardia. Good. What are some other signs or symptoms that you would see?
Clamminess.
Clammy.
Yes. Yes. Anything else you think of?
Dizzy.
Pale
They may,
skin.
they may be pale skin. Mhm. Good. What's going to happen with that fetal heart rate?
Drop.
It's gonna
Mhm.
decrease.
It's going to decrease too, right? If mom's hypotensive, tachycardic, baby's not going to be perfused well, so the baby's heart rate's going to drop too. Good. Okay. Questions? Want to do some case studies, questions over what we've covered tonight?
Sure.
Sure. Okay. Reinforcement of our content for tonight. You have a 28-year-old woman who is 10 weeks pregnant, admitted with a diagnosis of hyperemesis gravidarum. Oops. Which assessment finding is most concerning and requires immediate intervention? Okay, so we're looking for the one that's most concerning and requires immediate intervention.
Weight loss.
I've got you some answers. So A is dry mucous membranes with poor skin turgor. B is weight loss of 5 pounds over a 2-week period. C is a serum potassium level of 2.8 milliequivalents per liter. And D is reports of nausea throughout the day. Do you want me to repeat those or? Yeah. So dry mucous membranes, weight loss of 5 pounds over 2 weeks, serum potassium of 2.8, or nausea throughout the day.
See,
Yes. Yes.
Potassium.
Potassium, right. Why would potassium be the biggest concern?
Cardiac issues.
Yes, absolutely. Cardiac issues. Yeah, when your potassium is out of normal limits, you worry about those cardiac issues. Dry mucous membranes, that's an inconvenience, right? Weight loss over 2 weeks, that's a concern. But you know, if you have nausea and vomiting, you can lose a couple pounds just overnight, can't you? And then you gain it right back. So 5 pounds is significant weight loss, but still the most concerning when it says most concerning that requires immediate intervention. That's why the potassium is your most important. Would we be concerned about that 5 pounds of weight loss? I'd be concerned about it, but it's not going to require immediate intervention. Okay. Let's see. That was good. You have a 32-year-old woman that's 34 weeks pregnant and presents to the prenatal clinic with complaints of persistent headache, blurred vision, swelling in her hands and face. Her blood pressure is 158/102. And when you dip her urine, it's 3+ for protein. Okay. Which action should the nurse take first? So this is asking what is most important. Which action to take first? Instruct the client to lie on her left side and rest is A. B, administer acetaminophen for the headache as ordered. C, notify the healthcare provider immediately. And D, schedule the client for a non-stress test later in the day.
Notify the healthcare provider?
Yep, notify the healthcare provider. Yeah. Would you advise her to lay on her left side and rest?
Yes.
We would, but our question says, what action should the nurse take first? So whoever said C was correct. We need to notify the provider immediately. But yeah, we would tell her to lay on her side and rest because that's going to help bring her blood pressure down, isn't it? Her blood pressure is going to be at its lowest if she's laying on her left side. So that's a good thing to tell her to do. But the most important is notifying the healthcare provider. Would we give her some Tylenol for the headache if we had it ordered? Sure. We're not going to hurt anything by doing that, are we? But we'd call the physician first. And scheduling a non-stress test for later in the day. We would do that as well because we need to determine the well-being of this baby. And that's how we do that, is with a non-stress test. But again, the most important action that the nurse is going to take is contacting that physician. So all of those other things are appropriate actions or appropriate interventions. It's just they're not the first one. So the first one would be contacting the physician. Because she came in and said all the right things, didn't she? That we're looking for preeclampsia. Okay, good. You have a 30-year-old woman that's 28 weeks of gestation undergoing a prenatal visit. She was recently diagnosed with gestational diabetes after failing her 3-hour glucose tolerance test. The nurse is reviewing the client's recent glucose log and shows a fasting glucose level ranging from 100 to 110 and a 2-hour postprandial level of 150 to 165. Which nursing action is most appropriate at this time? So we're looking at the most appropriate action. A, reassure the client that these values are expected during pregnancy. B, instruct the client to increase her carbohydrate intake and to prevent hypoglycemia. C, notify the healthcare provider for possible initiation of insulin therapy. And D, advise the client to reduce physical activity until glucose levels stabilize.
What was the last one?
Reduce physical activity until glucose levels stabilize.
What were the other three? Sorry.
That's okay. How about I read the question again?
Yeah.
And then the answers again. Okay. A 30-year-old woman at 28 weeks gestation is undergoing a prenatal visit. She is recently diagnosed with gestational diabetes mellitus. After failing her 3-hour glucose tolerance test, the nurse is reviewing the client's most recent glucose log, which shows a fasting blood glucose level ranging from 100 to 110 and a 2-hour postprandial between 150 and 165. So fasting was 100 to 110 and 2-hour postprandials are 150 to 165. Most appropriate at this time. A, reassure the client that these values are expected during pregnancy. B, instruct the client to increase her carbohydrate intake to prevent hypoglycemia. C, notify the healthcare provider for possible initiation of insulin therapy. D, advise the client to reduce physical activity until glucose levels stabilize.
C.
Yes, C. Yeah. Because we don't necessarily expect those glucose levels during pregnancy, which was A, and increasing her carbohydrates to prevent hypoglycemia is not appropriate. And we know that we want to keep their glycemic index under control all throughout their pregnancy. So sometimes we do have patients on insulin just during pregnancy, and then afterwards they come off of it. So if it's gestational diabetes. So that's what she was diagnosed with. And that would be an appropriate action at this time. And physical activity lowers blood glucose levels, doesn't it? So there would be no reason to reduce physical activity until blood glucose levels stabilize. That's just kind of an odd distractor there in itself. Okay, that was good. Okay, you have a 35-year-old client that's 32 weeks gestation. She presents to labor and delivery with painless vaginal bleeding. She has a history of 2 prior cesarean deliveries. The nurse suspects placenta previa. What's her priority action? Perform a sterile vaginal exam to assess the cervical dilation. Place the client in Trendelenburg position to reduce bleeding. Prepare the client for immediate cesarean section. Place the client on bed rest and notify the healthcare provider.
Bed rest.
Perfect. Bed rest. Would you do a vaginal exam on someone who had placenta previa? No. If you know that a patient has been diagnosed with placenta previa, like with an ultrasound, you don't do a vaginal exam because you may put your finger through the placenta. And you don't want to do that. That would cause a hemorrhage. So no vaginal exams on patients who have been diagnosed with placenta previa. Trendelenburg to reduce the bleeding. You need to know if a patient's bleeding, so that's really not appropriate. Prepare for immediate cesarean section. She's only 32 weeks, so we need to be seeing what's going on. She shouldn't really be in labor at 32 weeks unless it's preterm labor. So we could notify the healthcare provider and put her on bed rest and see what's going on, because ideally we want to get patients to a point of viability or where the baby is going to have the best outcome possible. So this patient we may put on bed rest. If there's any indicator that they're having some labor, we may stop that because we don't want the cervix changing, and watch them for bleeding. And I mean, we may still have to go ahead and do a cesarean and get the baby out. But if we can stop anything that's changing the cervix, we would want to do that. And bed rest, like Cheryl was indicating, that helped with hers. So that's definitely an option for us. Okay. All right, I think that might be the last question I have for you. Nope, there's one more. A 29-year-old woman at 36 weeks gestation arrives at the emergency department complaining of sudden onset, severe abdominal pain and vaginal bleeding. She appears anxious and diaphoretic. Her vital signs are blood pressure 90/58, heart rate 122, and fetal heart rate is 170. She has a history of chronic hypertension and cocaine use. What is the priority action? A, apply oxygen via face mask, initiate fetal heart rate monitoring. B, administer IV labetalol to manage the maternal blood pressure. C, prepare the client for vaginal examination to assess cervical dilation. D, reassure the client and encourage slow, deep breathing.
Hey,
Yes. Yeah. What do you think's going on with her?
possible hemorrhage.
Yeah, she's abrupting, isn't she?
Yeah.
She's abrupting. You can say it, Valerie. That's what's happening. And that's really the only answer that's appropriate for her. Yeah, very good. Okay, questions? All right. Do you know what pica is? What's pica?
Where you crave and eat things that aren't food.
Yeah, where you're craving and eating things that aren't food. Which would be like dirt, charcoal, or things that people have said they craved. We think it's like a mineral deficiency that causes people to crave those kinds of things. What happens if you're craving ice? What's that an indicator of?
Anemia.
Anemia. Yeah, we have patients a lot of times that will say that they just keep eating ice chips, and it's usually because they're anemic. Okay. All right. I think that is the biggest part of what we needed to cover tonight. Let me go back to our. Okay, let's go ahead and take your second quick break. It's a quarter till, and we'll be here till 5:15. So we'll do about a 10-minute break. That'll bring us back about 5 o'clock, and then we'll just wind everything up, okay? And why don't you try to get into your math quiz and just make sure everybody can access that while we're taking a quick break, okay? I want to make sure that it's accessible to everyone. And then we'll be right back together and finish.
At 5?
Yeah, we'll be back at 5.
Okay.
All righty. Okay. Most of you are back. How about the math? Were you able to get into it okay? No one's having an issue not being able to open it up. Okay, that's good. All right. This week you have your OB math calculations that we were just talking about. You have a CJ Sim due. It's Jillian Kessler is the one due for this week. I wanted to talk about late submissions a little bit. Back when we went over our orientation, we talked a little bit about late submissions and that you do get credit for something that you do late, but you just have to contact me first in order to submit it late or to have it graded. So if you're going to be late, you have 7 days past the deadline in order to submit. If you have questions about that, just go back and pull up week 1, the orientation PowerPoint, and it will give you the details. But if you go ahead and submit and you haven't contacted me first, I can't grade it. So be sure that you reach out. And like I said, it sounds cold, but when we did our orientation, I don't care if you worked over or you forgot about it or you had a sick child. It really doesn't matter to me what the reason was that you were unable to submit by the deadline. The fact is, as long as you communicate to me that you didn't get it in by the deadline and you still want to submit it, you communicate that to me and you can still do it. You get that 10% penalty, but you can still submit it. But I'm not supposed to grade it if you haven't contacted me first. So be sure that if you're going to submit something late, that you reach out to me and say, hey, I was late. I didn't get this done on time. Can I still submit it? I will respond and say, sure, submit that. And then I'll go in and grade it. But I need that paper trail that you've reached out to me and then I've told you to go ahead and submit it. So if it ever comes back on us that we've had that communication, so you don't want to lose those points. I mean, and I know sometimes that school and work and family is a lot and it's easy. Sometimes you just run out of time and sometimes you just frankly forget. So those things happen. But 90% of your grade is better than a 0. So reach out and say, I'm late on this. I need to get it in to you. And the same thing goes for your discussion questions. We had discussion board last week, and I really enjoyed reading your discussion post. But if you don't get that Wednesday evening post in by Wednesday at midnight, then you miss out on the 10 points that are associated with that. Does that make sense? Not just a couple points off for being late, but it's you don't get any points for the discussion. So and unless you reach out and say, hey, I forgot it was Wednesday, it's Thursday, can I go ahead and submit it? And then I'm going to say, yes, submit it. And then you just get that 10% reduction. Okay, so be sure that you recognize that as a reduction too. Sorry. So again, be sure that you're reaching out to me if you're going to be late on submissions, because it's really important so you get all of your points. And also, like on your CJ Sims, there were several this last time that took a screenshot, but it didn't have everything on it. So I asked for it to be resubmitted. Be sure that you do resubmit those. Be looking for that. If something happens, your CJ Sim or your NCLEX questions, if I ask for it to be resubmitted and it's resubmitted the day after the deadline, you'll still get credit for that. If it's something that I've asked for, you can resubmit it. You may not see it in time, so you can resubmit that after the deadline and not get deducted credit for it or deducted points for it. But be sure you go back and look at those, because there was also several on your NCLEX questions that you did a screenshot and didn't download the entire document, and I need to see, like, I don't know, it's like 14 pages, but I have to look at what questions you did to make sure that they were the correct questions that you answered. So be sure that you upload that entire document for me. Okay. So, and I messaged anyone that fell into that category. I messaged you to let you know that I needed it resubmitted. So if you haven't done that, go back in and look at those things and resubmit those so you get credit for them. Okay, questions? Next week, we have another quiz. Be sure you're going in and looking at all of the different sessions that are available. Instructors, the full-time instructors have lots of different sessions throughout the week that they're holding. I know Dr. Zeller had one last night, but I don't think a whole lot of people are taking advantage of that. And it's a good opportunity to ask questions and really get some good information. So take advantage of as much of those as you can. I go back in and I post those. Have you guys been looking at those? Have you been going back and watching the recordings? So you see where they're posted? Okay. Okay. All right. Any questions? Okay. It seemed like just a couple chapters wasn't very much to go over after we've had so many in the past, was it? Tell me again what you would use for an antidote for magnesium sulfate?
Calcium gluconate.
Gluconate.
Gluconate, yeah. What are you going to assess on your patients who are receiving magnesium?
Blood pressure.
You're going to assess your blood pressure.
Respiration rate.
Respirations.
Deep tendon reflexes.
Reflexes, good. Urine output. And magnesium blood levels. Good. Let's see, what else did we talk about today? Abruption. What color's the blood?
Dark red.
Bright.
Is it bright or dark?
Dark red. Abruption. Bright red if it's a placenta previa, because it's coming from the maternal side of the placenta. So it's bright red bleeding. Abruption is dark red. Which one is painless?
Previa.
Previa. Which one has a very firm, rigid abdomen?
Abruption.
Abruption. Good. Which one is often caused by cocaine use?
Abruption.
Abruption. Yeah. What causes placenta previa? A low-lying placenta.
Yeah.
Yeah. Yeah. It wasn't a trick question. Yeah. 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 The implantation of the placenta is not in the fundus of the uterus where it should be. It's down close to the cervix. Yeah. What kind of complications do you see when blood sugars are out of control early in pregnancy? What would you see with the fetus?
Big.
Big or small?
It could be big or small, either one. Yeah. If they're not being perfused well because mom's blood sugar is out of control, it may be small for gestational age or intrauterine growth restriction. So you can have a small baby, or you can have macrosomia. You can have a big one too. So yeah, can go either way. You can have stillborns from blood sugars being out of control early on. What about birth defects? Birth defects are a problem with early glycemic index being out of control. So that's the early ones. Late. What do you see in the fetus when it's late? Does this mean big baby? Big. Yeah, big babies. Macrosomia. And then the complication of macrosomia is what at delivery?
Like a C-section?
C-section is what it would result in, but why would we end up doing a C-section?
Because the
Shoulder
babies don't fit.
Yeah, shoulder dystocia. Yeah. The baby's at risk for hypoglycemia after delivery because with mom's blood glucose being high, the baby's blood glucose is going to be used to being up. And then once the baby is delivered, you're at risk of hypoglycemia. Okay, so we're going to have to monitor it closely for hypoglycemia. Polyhydramniosis, so too much fluid around the baby is a risk for these babies late in pregnancy. Preterm birth and stillborn. And remember, we talked about stillborn would be after 36 weeks. So that's why we go ahead and deliver them, not only because they're often big babies, but often because the risk of stillborn increases after 36 weeks gestation with a diabetic. Okay. With preeclampsia, what else besides the blood pressure? What else do we see with those clients?
Headache.
Headache, unrelieved with Tylenol or acetaminophen.
Floaters in the eyes.
Floaters, some kind of visual
Or like-
disturbance. Yeah. Blurred vision, spots, floaters, squiggly lines. They're going to complain of something with their vision. It's neurological. There's some kind of neurological visual issues. What else?
Tachycardia.
I'm sorry, I didn't hear you.
Tachycardia.
Not usually with preeclampsia. Not specifically. Did somebody say proteinuria?
Yeah, proteinuria,
Proteinuria.
thrombocytopenia,
Yes. Yes, thrombocytopenia. Your platelets drop.
increased liver enzymes,
Increased liver enzymes. And when you have that, what kind of physical symptom are you looking for?
edema,
Maybe they do have edema, but with the liver involvement, you're looking for
increased blood pressure,
yes, you're going to have increased blood pressure. You're going to look for right-sided upper right quadrant. Yeah. because the liver may be enlarged. So you're going to be looking for tenderness and over top of the liver. Okay, anything else you can think of? The edema that you were talking about, where do we typically see it?
Face.
Face and hands, which are not typical places that you swell with pregnancy.
Your eyes.
Yeah, periorbital edema. Yeah.
Part of their stomach.
I'm sorry.
Like, didn't you say part of their stomach swells?
With the liver enzymes being elevated, if there's liver involvement, the right upper quadrant over top of the liver gets puffy. So
Yeah.
there may be some abdominal swelling or tenderness in that area that you're looking for. No. Okay. Okay, what about the nausea and vomiting? What makes the difference between nausea and vomiting and hyperemesis gravidarum?
It's nausea and vomiting can be treated, and I can't say it, gravidarum it can't be treated.
Yeah,
Normally
yeah,
severe.
yeah. It's gravidarum is often uncontrollable and leads to complications like electrolyte imbalances that we're talking about, like especially your potassium, and can lead to metabolic alkalosis. The weight loss is an issue too. And how long does it last?
The second, third trimester,
Pregnancy.
all the whole thing.
Yeah, it can be through your entire pregnancy. Okay. I think you guys have that stuff down well. Good. Okay. If you want to reach out to me to go over quizzes or exams, anything, send me an email or a text and just give me 3 dates with times attached to it that you're available. And I'll do my best to work in the first one. But like I said, it's been kind of a busy week this week. So that's why I'm asking for 3 instead of just 2. But we'll get you in. All right. You guys have a great week. Happy studying.
You as well.
Bye. Congratulations,
Bye.
Alex.
Congratulations.
Hey, thank you. I appreciate you. Thank you.
Bye.
Bye.